Assalamu alaikum. Now, now I would like to discuss about psychiatric emergencies. First of all, serotonin syndrome. Any drug that increase 5-hydroxytryptamine, any drug that increase 5-HT, like psychiatric drugs, MAO inhibitor, SSRI, SNRI, TCA, vilazodone, vortioxetine, buspirone, these drugs, and some non-psychiatric drugs like tramadol, ondansetron, triptan, linezolid, MDMA, dexmethorphan, meperidine, and St. John's wort. These drugs can cause serotonin syndrome. How do you find this serotonin syndrome? There is increased activity like hyperreflexia, clonus, hypertonia, tremor, and seizure. Autonomic instability, hyperthermia, diaphoresis, diarrhea, and altered mental status. So, increased activity, autonomic instability, and altered mental status. These three A's done by the S. That means serotonin syndrome. And it happens due to these drugs which increases 5-hydroxytryptamine. All the psychiatric drugs and the non-psychiatric drugs can cause this serotonin syndrome. Linezolid, MDMA, dexmethorphan. These are the other drugs which can cause this sort of serotonin syndrome. What should you give when there is increased activity, autonomic instability, and altered mental status? Give benzos, give benzodiazepine and supportive care. Give benzos and supportive care. Another drug is cyproheptadine 5-HT2 receptor antagonist. If no improvement after giving benzos, then you should give cyproheptadine. Avoid stimulants, serotonergic, uh, avoid simultaneous serotonergic drug and allow a washout period between them. Then hypertensive crisis. In hypertensive crisis, eating tyramine rich food like aged cheese, card meat, wine, chocolate while taking MAO inhibitor. Eating tyramine rich food while taking MAO inhibitor and some insufficient washout period when insufficient washout period when switching to antidepressant to and from MAO inhibitors. Eating tyramine-rich food while taking MAO inhibitor, this can cause this hypertensive crisis because tyramine displaces the other neurotransmitter in the synaptic cleft and increase sympathetic stimulation. Continuous sympathetic stimulation, increased sympathetic stimulation. Treatment is phentolamine. Then NMS, neuroleptic malignant syndrome, antipsychotic, typical or atypical antipsychotic plus genetic uh, predisposition, malignant myoglobinuria, fever, encephalopathy, vitals unstable, enzymes increase CK, muscle rigidity, malignant fever, malignant is myoglobinuria, fever, encephalopathy, vitals unstable, increase enzymes and muscle rigidity. led by rigidity. In neuroleptic malignant syndrome, dantrolene dantrolene is the treatment, dopaminergic, bromocriptine, amantadine, benzodiazepine, and discontinue the quasi-revision. Dantrolene, bromocriptine, amantadine, benzodiazepines can be used. In delirium tremens, alcohol withdrawal occurs 2 to 4 days after lasting 2 to 4 days after last drink. Classically seen in hospital setting when an inpatient cannot drink. Altered mental status, hallucination, autonomic hyperactivity, anxiety, seizure, tremor, psychomotor agitation, insomnia, and nausea. Longer acting benzodiazepine can be given. Longer acting benzodiazepine can be given. Then acute dystonia. In acute dystonia, there is typical antipsychotics, anticonvulsant, and carbamazepine or metoclopramide. Typical antipsychotics, convulsant, carbamazepine, and metoclopramide. Sudden onset of muscle spasms, stiffness, and/or of low gyrate crisis occurring hours to days after medication use. Sudden onset muscle spasm, stiffness, and ocular crisis after hours to days after medication use. This can cause laryngospasm requiring intubation. So benztropine and BDs is the treatment. Benztropine and diphenhydramine is the treatment. Benztropine and diphenhydramine is the treatment in acute dystonia. In lithium toxicity, this increase lithium dose, decrease elimination like AKI, medication affecting clearance, AC inhibitors, azide, NSAID. It's a narrow therapeutic index. It can cause nausea, vomiting, slur speech, hyperreflexia, seizure, anxiety, NDI. Discontinue lithium, hydrate aggressively with isotonic sodium chloride, and consider hemodialysis. High yield, high yield, high yield. TCA in tricyclic antidepressant, convulsion, coma, and cardiotoxicity. 3C is convulsion, coma, and cardiotoxicity due to sodium channel inhibition. Supportive treatment, monitor ECG, sodium bicarb to prevent arrhythmias. Convulsion, coma, and cardiotoxicity happens. There is a long QT and QRS, a long QT and QRS. This is tricyclic overdose, ECG, sodium bicarb, and activated charcoal can be given. This is all about psychiatric emergencies. Hope you enjoyed.